So tiered systems of care are apartheid. Penthouse care for some, bargain basement care for others, and no care for the very unlucky. This is a caste system. Public option, expansion of Medicare or Medicaid continue to allow industry control and expand corporate profits by treating us as human capital. We are labeled income generating units, not human beings. So lack of cost transparency and the absence of price controls leave us vulnerable to deceptions, graft, and greed. Today, we want to demonstrate why the current industry-friendly reforms being touted are not the solution, but rather a continuation of a dangerous and destructive system of corporate control over our lives. So it is my pleasure to introduce our first speaker, Dr. Paul Song, who is the president of Physicians for National Health Program, California. And he is a longtime outspoken champion fighting to reform this system with single payer universal health care. Dr. Song has also worked on healthcare. Where's Dr. Song?
I'm here.
Paul? There you go. Paul, the wrong Paul was up. So Dr. Song has worked on healthcare policy at the Office of California Insurance Commissioner. A practicing oncologist for over 25 years, Dr. Song currently cares for low-income patients at Los Angeles area hospitals and is the chief medical officer at a biotech company devoted to making cancer treatments affordable. A frequent news commentator, Dr. Song addresses the immorality of the current profit-driven system and its life-threatening impacts on us all. With experience at some of the nation's top medical centers, Dr. Song identifies the failures of our healthcare system as a result of hospital chains, big pharma, and the private insurance industries. In keeping with our theme of single payer means everybody in, Dr. Song will explain why the alternative of public option or any tiered plan is not a solution to our healthcare crisis. We welcome Dr. Song.
Thank you so much for having me. I am going to share my screen if possible. Okay. And let me get that up and running. So again, thank you so much. What I wanted to do was to just explain a little bit about the current state of our system, how COVID has really exposed what's wrong with our system, and then really get down to why a public option will not be suitable. So I actually graduated from medical school almost 30 years ago. It'll be 30 years this May. C. Everett Koop was the Surgeon General at the time. He administered the Hippocratic Oath. And the only part of the Hippocratic Oath that I remember is this part that said, I will follow that system of regimen, which according to my ability and judgment, I consider for the benefit of my patients and abstain from whatever is deleterious and mischievous. And I can tell you since that time that I took the oath, I've really just been disgusted by how deleterious and mischievous our healthcare system is. As an oncologist, I've seen far too many of my own patients go bankrupt or basically run out of all options because insurance companies would not cover their care. And I started to really question what was really going on with our system. And just to point out, if we look at how our insured have financial issues compared to our uninsured, it's pretty amazing that our insured actually report having much more difficulty in terms of borrowing money from friends and family, unable to pay for food, heat, and housing, using up all of their savings, putting major purchases on hold. And these are the people that have insurance. And I often wonder, what is it about our system that gives you insurance, but then doesn't protect you from really all these financial issues once you get sick? And just to point out again that if you look on the left, not only are we spending roughly twice as much per person or percent of our GDP on healthcare, but we also have a lower life expectancy. And on the right, if you look at the cost of healthcare, but down below, the number of people that report having difficulty with healthcare spending each year. So we're spending an exorbitant amount of money and really not getting what we deserve in terms of healthcare. And I will point out that if anyone wants these slides, I'm happy to share them with you all, but just to give you a little bit of background of where we are. So the Affordable Care Act was signed into law now over 10 years ago. But what was really interesting is after it was signed into law, the Lancet, which is a highly reputable medical journal, took the highly unusual task of dedicating a whole issue that basically said the health reform process exposes how corporate influence renders the US government incapable of making policy on the basis of evidence and the public interest. And really what happened was there were 3,300 registered healthcare lobbyists for the 535 members of Congress. They were spending more than $1.2 million a day. And this is why there was no public option, no insurance rate regulation, or no drug price regulation in the Affordable Care Act. And as a result, what happened? Well, first, let's talk about corporate welfare, right? After the Affordable Care Act, it's now that most of the private insurers get most of their revenue from Medicare and Medicaid. So when you hear private insurance, it's not really private, it's just being paid for by us, and it's a corporate subsidy to all of the insurance companies that lobbied so hard. And then let's look at, what's happened to premiums and deductibles over this period of time. If you look at the amount that each of you was being asked to contribute from your paycheck toward your employer-sponsored plan, that's gone up dramatically on the front end, but on the back end, if you get sick, you're asked to pay more in terms of copays and deductibles. And let's face it, many people are in jobs not because they like the job, but strictly because of the healthcare benefits. And yet they're being asked to contribute more of their paycheck and have less take-home pay. So if you look at wages and inflation, it's remained relatively flat over the last 11 years, but all of the amount that you're actually paying out of your own pocket of your salary that's basically remained stagnant is more and more. And let's look at one other thing that's very interesting called the Healthcare Unaffordability Index. So basically what it is, it's the cost of family health insurance divided by the median household income. And if you look at the Health Affordability Index, it's really at an all-time low, meaning now the average American spends 1/3 of their paycheck towards healthcare insurance. So what's happened with this? While we're being asked to contribute more and health insurance premiums have doubled, even though the fact that insurers report record profits. So we have a system that's grossly inadequate, a system that has been really corporate welfare for the insurance companies that continue to get richer and richer off of our backs, the taxpayers. And it's no wonder that if you look at from the start of the Affordable Care Act, this is just showing you a 2-year window that the number of Americans that said that it's more difficult for them to afford their monthly premiums has gone up. The number of doctors who said it's more, a number of people that's gotten more expensive for them to pay for their copays or deductibles has gone up. And as I started to begin with, this is in 2018, that 42% of new cancer patients lose their life savings. So by all means of controlling costs, the Affordable Care Act has not done that. And it's no better, my cancer patients are no better off now than they were before the Affordable Care Act. So let's also talk about underinsured. So these are people that have coverage, but the card for which their insurance coverage is printed on isn't really worth the paper that it's printed on. And this is just showing you that between the ages of 19 and 64, the number of people that have underinsurance, meaning if they got sick, they would most likely become bankrupt, is about 42% for individual plans, 28% for overall, and roughly 26% for employer-sponsored plans. So even if you're getting coverage through your employer, like a lot of corporate Dems like to tout as the solution, it's not really going to protect roughly 1 in 4 of us. And then the number of people that have put off seeking care because they can't afford the copays and deductibles is roughly 1 out of 3, and it's particularly high among communities of color. And let's not forget, because there was no prescription drug pricing controls, that 45 million Americans did not fill a prescription in 2016 because of costs, and 22% of seniors don't fill prescriptions because of the cost, and yet Medicare is prohibited from negotiating drug prices. And then the final thing I just want to point out about our situation is that the narrow network. So what that means is that if you live in a certain area, chances are your ability to see providers is not great. A narrow network means that your insurance plan only has contracts with less than 1 out of 4 of all the doctors in your area code or zip code. And just to point out that narrow networks still remain a major, major problem. So again, I would ask, why are we spending so much and getting so little? So we have this convoluted plan where you will maybe have United Healthcare one year, then next year you have Aetna, maybe the next year you have Medicare, you lose your job, and then you go to Medicaid, and it's up to your insurance, your doctor's office or your hospital to figure out, am I still in your network? What's your copay? What's your deductible? Who can I refer you to? Where can I send you to be admitted? And it's this convoluted system that really takes money away from actual patient care. And just to show you that between 1970 and 2015, the number of overall administrators has ballooned while the number of doctors has remained stagnant. And down below, if you look at the rise in healthcare expenditures for private insurance, it's ironic that it mimics the exact cost or the curve of the growth in administrators up above. And it's gotten so bad that the United States is spending more on administrative costs than we do on long-term care. And if you look at down below per capita, how much we're spending on administrative costs, and this is from 2019, so just last year or 2 years ago, it's not even close as to what the other countries are spending on administrative costs. And then look at how much we actually spend on long-term care. And when we have an aging population, and this is one of the areas that, wouldn't it be much better if we spent some of that administrative dollars on long-term care? In fact, if you look at Duke University, they have they have more billing clerks than they do hospital beds, and they're spending roughly $1 out of $4 in their budget on administrative costs. So it's no wonder we have the least efficient healthcare system. And what coronavirus did was really expose all of the fallacies of our current healthcare system. Sadly, we've crossed over 500,000 people that have died. And unfortunately, I think our society has become sort of numb to the number of people that have died. And may we always keep these people in our minds. But just to show you that during the Democratic debates, Joe Biden used Italy and all of the countries that had a single payer or socialized healthcare system as examples, saying that the death rates were so bad. But now look what's happened since Joe Biden made those statements. If anything, the death rate in the United States has escalated, and the countries that have done a good job with have a single payer or socialized healthcare system. The other part is that you heard Amy Klobuchar talk about how Bernie's plan would kick hundreds of millions of people off their employer-sponsored healthcare. But let's not forget, in this pandemic, those that are uninsured are so many of our frontline workers. And yet, if you look at the number of people who lost their employer-sponsored healthcare, we've now had over 14, some people estimate as high as 20 million people have lost their healthcare coverage that's been tied to their employment. But if you look at the number of people who've lost their healthcare in countries during the pandemic, you look at these countries that have a universal healthcare system, nobody's lost their healthcare. So I think many of us would argue that healthcare is a human right and not a job perk. And the other part is, you heard people on the right saying that, you know, a socialized medical system or a single payer system would lead to rationing of the care. And this is just to show you that as recently as January of this year, we were rationing care here in Los Angeles because a lot of the safety net hospitals were overwhelmed because of long times taking care of uninsured patients. They haven't been able to keep up by building out their ICUs and things. So we've been rationing care here in the United States. So all of the lies we've been told about our healthcare system were further exposed during this pandemic. And then the other part is, you have a lot of our corporate Dems who want to just expand Medicaid, but just to point out that Medicaid in our state is an apartheid system. It is separate and unequal. There have been several stories in the last 3 months showing how COVID has really, again, exposed that, the number of doctors that participate in Medi-Cal, the number of patients that have died waiting for care on Medi-Cal, and that, as you can see down below, LA's poorest patients endure long delays to seek medical specialists. So for those people, particularly in our state assembly, that keep touting Medicaid, 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 they are really sentencing people to die unnecessarily. But let's look at who has done well during the pandemic. It's the insurance industry. They've had record profits during this time. So it's no wonder that during the pandemic, the more and more people have said they would love to, particularly those that have lost coverage, to now have a Medicare system for everyone who's lost coverage during the pandemic. So here are the current problems, and I ask you to keep these in mind as we look at whether or not a public option will solve these versus a Medicare for all system. We have 31 plus, some people estimate as high as 34 million uninsured. We have no coverage for undocumented brothers and sisters. We have no insurance rate regulation, no drug pricing control. We have narrow networks, high copays and deductibles, all this administrative waste, an overall inefficient system, and lack of health security with job loss. So President Biden ran on protecting and building upon the Affordable Care Act. You can see some of the things that he wanted to do, but the biggest thing he wanted to do was create a new public option. And here are the key features of the public option. It would be a government administered public option plan, but now people are saying it probably would be privatized, held, administered by insurance companies. It still retains the current structure of our multi-payer system. So let's look at 1965. I was born 4 weeks before Medicare was signed into law. Just to show you that despite taking care of an older, sicker population with more chronic medical conditions, that Medicare has done a much better job at controlling costs and having higher satisfaction compared to the prior private insurance industry. So instead of this convoluted system of multi-payers and multi-administrators, wouldn't it be simpler to just have a single payer system, which is what we all believe in? So if you had to diagnose a problem, I would say one of the biggest problems is the large parasite that is sitting in our healthcare system, which is the private insurance industry. And just to point out that when Bernie initially proposed his plan, Democrats and Republicans alike said that it was too expensive. It was going to cost $32 trillion. Yet on Fox and Friends, the number of people that registered to the poll said that they would still support it. But what was disingenuous, not only for Fox, but a lot of the corporate Democrats, was they failed to mention that the Sanders plan would actually save $2 trillion a year compared to the current status quo while insuring everyone. But a public option plan has been now estimated would add $700 billion to our deficit. So you have a single payer plan that would save $2 trillion over 10 years, whereas a public option would just add another layer of complexity and cost $700 billion over 10 years. So here's the difference, right? Medicare will cover everyone. Public option would still exclude our undocumented brothers and sisters. It would be, Medicare would not be tied to employment. It would give you choice of doctors, no narrow networks, and it would basically negotiate deep discounts in drugs and costs of services and eliminate all the administrative waste, where a public option would continue to maintain all of the inefficiencies that exist. So Shirley Chisholm, back in 1972, she ran as a candidate who was unbought and unbossed. She said, "We have never seen healthcare as a right. It has been conceived as a privilege available only to those who can afford it. This is the real reason the American healthcare system is in a scandalous state." I would say the biggest reason the American healthcare system is in a scandalous state is because we have too many politicians who are bought and bossed by the pharmaceutical industry and private insurance industry. And as you know, I got into trouble now about 5 years ago because I call these people out. Just to point out what I meant by this is, if you look at the number of Democrats who voted against Medicare for all, they've received over $43 million from the private insurance industry and pharmaceutical industry. So while the term I used may have been insensitive, the truth behind it is still the truth. And let's not forget the Partnership for America's Healthcare Future, which is a front group for hospital associations, insurance industries, and pharmaceutical industries. It's run by a former Hillary Clinton aide and other Democratic colleagues. They've already gone out of their way to basically undermine the public option. They said within 24 hours of the launch of the industry's new ads, anonymous Democratic congressional sources were telling the Hill that Democrats were less likely to bother with a public option. So again, you see these are Democrats who are undermining any meaningful healthcare reform in our country, not the Republicans. And so let's look at how the impact of the public option and where things are and what the likelihood of these passing. So if you look, the likelihood of gaining traction in the public option is low, and look at who the impact is. Same thing with negotiating drug prices, but everything that will increase utilization, increase profits, the likelihood of gaining traction is very high. And just to point out that it's not as if the money isn't there. Here in the state of California, 70 cents of every healthcare dollar is already being paid for by us, the taxpayers. If you look at it in terms of tax breaks that we give Apple and Google to provide healthcare to our employees, the number of state employees that get healthcare, teachers, police, firefighters, all of our Sacramento politicians, they're all being subsidized by taxpayer money. So the money is there. So as we move forward with the debate on AB 1400, let us not forget that we're already paying for a universal healthcare system. So finally, I'll just say that, you know, during the debate, you had Hillary Clinton saying that giving healthcare to everyone, single payer Medicare for all, was like giving everyone a pony. And I'll just say, where's our friggin' pony? It's time. We deserve a pony. And with that, I'll just say thank you so much for allowing me to speak today.
Thank you so much, Dr. Song. Really appreciate that. We'll have questions at the end when everybody has given their presentations. So, Erica?
Hello, everybody. So I am super excited to introduce my friend, Jeanna Harris. So you there, Jeanna? I think the Zoom is funny and I just can't see you. There you are. All right, so Jeanna is a nursivist, that is nurse plus activist, and has worked as an RN in multiple clinical settings, including medical, surgical, cardiac rehab, and acute dialysis transplant. Currently, she is a regional manager of inpatient care management, facilitating the coordination of patient services across the continuum of healthcare needs. This has given her an administrative overview of our healthcare delivery system and of the patient experience navigating its complexities. Jeanna represents the 54th AD as a member of the LA County and State Democratic Central Committee, has been a DNC delegate for Bernie Sanders in 2016 and 2020, and is a highly valued member of the Healthcare for All Los Angeles leadership team. She has participated in numerous panels, vigils, and rallies because she knows that our healthcare system is fundamentally broken and that the path to improving the healthcare system is to have universal, comprehensive, high quality, guaranteed care, because everyone deserves healthcare. Medicare for all is a recurring phrase for reform, but is it enough to merely expand Medicare or Medicaid to everyone? Or do we need a broader reform to cure our broken system? Jeanna Harris will explore what Medicare is and what it is not, and why we need single payer healthcare now. And with that, my friend Jeanna.
Thank you, Erica, and thank you all for tuning in on this lovely Saturday. Hello, CPA. It's good to see you guys again. I so wish that we were in person because this convention would have been so lit just with how many people are speaking alone. Like, I was just like, oh my God, all my friends, we're all, you know. Anyway, so yes, I'm here to tell you exactly what is Medicare. We say Medicare for all. You hear us keep saying Medicare, 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 but do you really know what it is? And I'll be honest, you guys, right now in my current capacity, I'm not going to say who I work for, but I am that over exorbitant administrative cost, administrative cost. And the good thing is, though, is that someone like me is there to advocate. It's exhausting trying to advocate for what's right in a very corrupt system, but it's helped me learn. And so I'm going to pass some of the things I've learned to you. I'm going to share my screen, and this is just me honestly putting together some thoughts. You know, this is like what I have learned throughout, you know, me working. I've been in this role for now 6 years or so. So, you know, I've learned quite a little bit about Medicare. So Medicare, well, what is it? Medicare is a federal health insurance program. You can say company pretty much. And you're like, yeah, Jeanna, we know that. It was signed into law into 1965. If you want to know how that happened, I encourage you to watch Power to Heal, because you'll see that once again, the civil rights movement helped bring forth Medicare. And it covers people 65 plus, people with certain disabilities, and people with end-stage renal disease requiring dialysis or transplant. So it covers more than just the old folk. But you know, you have to still be pretty sick to get covered under Medicare when you're not 65. There's two types of Medicare. So you have the original Medicare, which we call AB, or you'll hear it say in my world, fee for service. And then you have the newer part, which is Medicare Part C, which was the insurance plan's way of digging into this. They were looking at it and they said, we want in, and they created Part C Medicare. We're going to talk about this a little bit more because I know I just confused you already. 2 slides in and you're confused. I am too, don't feel bad. All right, so what Medicare ABCD, what does it mean? Not free, that's what that means. So you have Part A, hospital insurance, okay? This covers your inpatient hospital, skilled nursing facility. I put in parentheses up to 100 days per benefit period because people think that once you have Medicare, you're just covered. You're not, I'm sorry, guys. And so you get 100 days per benefit period. At the end of that 100 days, if you still need more long-term or more, skilled nursing care, grandma, mom needs more nursing home care, guess what? You either have to have a private pay, like you arrange a payment situation with the nursing facility, and that's about $600 to $700 a day, to be honest, or you have a secondary insurance like Medi-Cal, which we'll get into in a little bit. So then it also provides home health care. Home health care is not a caregiver, okay? So home health care means I'm sending a nurse to your house to give you an IV. I'm sending a nurse to your house to do some type of therapy. I am not sending a nurse to your house just to help you bathe. That's not a covered benefit. Under certain instances, it might be, but good luck getting that approved. So often, this Part A, is premium free if you've paid Medicare taxes, like through your paycheck, for more than 40 quarters or 10 years. But if you haven't, you could pay up to a premium of $471 per month. That's if you haven't met that previous requirement, but most people meet the previous requirement. So Part A, typically, covered. Now, Part B. This is outpatient medical. So you have your primary care, specialist care, medical supplies, preventative services, not free. Premiums are about this year, 2021, are $148.50 per month for yearly incomes less than 88K, which is most of our seniors. If you're a senior citizen on Medicare and you're pulling down more than $88,000, congratulations to you. But that is nobody I know. Your mom, your dad, grandma, grandpa, aunt, uncle, probably paying this premium every month, okay? And that is on top of a $203 deductible. And then after you meet your deductible, you still have to pay a 20% co-insurance for, the Medicare approved services like your doctors, outpatient therapy, and medical equipment like a walker. You fall, you break your hip, you need a walker to go home. Guess what? You have to pay 20% of that. And in my role in case management, when we're trying to arrange these things for you to go home from the hospital, the medical equipment company wants their money too. So they'll call me back and say, well, we talked to the patient or we talked to the family and they can't afford their copay. I can't waive copays. That's one thing I can't do. I cannot waive a copay. So what do? You can't afford the 20% and I can't waive the copay. So what I've had to do is before COVID, when I was going to bedside more often, we would go to Amazon, we would go online trying to find cheaper medical equipment than, that to offset that copay. This is America. Part C, which I was talking about how the insurance companies got their hands into Medicare. Part C is what we call Medicare Advantage. And this is currently what I operate under, okay, on my day-to-day. It's offered by health plans and it often includes extra benefits like vision, and premiums are a little lower. But the network, tiny network, like Dr. Song was saying, they restrict the network and makes it very difficult. You have to stay within the network or things aren't covered. And it makes it a little difficult to navigate. Typically it covers and prescription cover, well, it does cover prescriptions as well. Premiums vary, so that's why I don't have an exact number. It depends on what plan you choose. Of course, the higher end plans with more freedom of choice are the more expensive. Basically, you pay for choice. The cheaper plans are more like the HMOs and have very, very tight networks to work within. But of course, if you want more freedom of choice, then you pay for it. Not quite the most fair thing now, is it? So they charge their premiums, deductibles. The plan decides how much you pay for covered services, and then what you pay, it changes basically on January 1st. So you get a notice saying, okay, your premium's going up $50 or $100 or whatever, and it goes into effect on January 1st. That's just what happens. But still, typically, it's cheaper than Part B with the $148.50. So people are moving into Part C almost by force because they cannot afford to stay under Part B, if that makes sense. I hear that a lot when I ask people, well, what made you come to my group? And they're like, I couldn't afford it. I couldn't afford this, So now we have Part D. Part D is your prescription drug coverage. And I want to talk about the donut hole. I know that Dr. Song, being, in oncology, for sure probably knows about patients hitting that donut hole. And it's basically a coverage gap. Once you have received, or once they've paid for about $4,000 worth of medication costs, you now become responsible for paying up to 25% of that prescription cost after you've hit this donut hole, okay? And you went from paying maybe a little bit of money for Part D, and then you had maybe a little bit of copay, a few dollars, $5 or something, but then you have this really expensive medication. I like to use an antibiotic that we give out sometimes for really bad infections called vancomycin. Very expensive orally or given in a pill form. And even pharmacists have asked us to tell doctors not to prescribe this drug because it tosses people into the donut hole and then they can't afford it. So now you have an infection that needs an antibiotic that can't be treated because you can't afford $600 or $700 a month for this treatment. Another one that I just dealt with this past week was an anti-neoplastic agent, or basically a chemo med called Blincyto. Blincyto is $4,000 a dose. So yeah, that's not really going to work for our poor seniors that are on Medicare. But is there an option? No, I don't have any other options. I'll have the doctors come back and say, well, there's no other drug I can prescribe. They need this one. And then what do? Here's a sad caveat that I didn't include here. In those commercials, those drug commercials, you'll see them say, oh, contact AstraZeneca for assistance with affording this medication. Guess what? If you are under a government sponsored program, typically you're not a candidate for that because you're under government sponsored. Those are for, private pay. So if you read the fine print on those programs that they're offered from the plans and from the manufacturers, typically they'll say, oh, well, if you're under a government sponsored Medicare, Medicaid, you don't qualify. So guess what? Now you're excluded. Yeah. And then also one thing, if you don't pay your monthly premiums with Medicare, and you will get kicked off within 90 days. They'll send you, your bills due, your late notices. And then after 90 days, boop. So that's what's wrong with Medicare right now. Now let's talk about Medicaid, Medi-Cal. So, it's a public health insurance program basically for low income, right? But it includes children, seniors, people with disability, pregnant women, certain medical conditions like TB, breast cancer, HIV, AIDS. It's financed equally from state and federal government, right? And then it also covers refugee status for a limited time, but it's very income specific, means testing. So here in this little corner, and I'm sorry if it's tiny, I'm not the best PowerPoint person. So if you see here, it says family size 1, the federal poverty or the limit to qualify for Medi-Cal is that you have to make this amount or less. This isn't the minimum, this is the maximum that you can make or have income to qualify for Medi-Cal. $17,000 is not even true. That is so below the true poverty wage that I can't even say it, but that's because the people who do this are just out of touch. So what does it cover? Well, it's pretty comprehensive, honestly, and it covers dental and it covers prescription drugs. And, it's very similar to Medicare, but of course, like I said, it includes maternity. Also, mental health care is another big thing. It also covers pediatric services, including oral and vision, and then it also covers dental. Medicare does not cover dental, FYI, unless you get into a Part C program where that just gives that as an additional benefit, but Medicare doesn't cover dental. So when I get seniors who have really bad teeth, you know, because they've gotten old, their teeth have gotten kind of old and nasty, and they need to see a dentist, they may not have dental coverage and they don't know that they don't have dental coverage. They think Medicare just covers it all. And what happens is we now end up doing something more expensive, which is I'm going to send you to an oral surgeon because the oral surgeon is covered under Medicare, to have the oral surgeon just remove your teeth because it's covered, than just having you go see a dentist. Does that make sense? It does not make sense. And I'm confused, and I'm sure you are too. So these are comprehensive what Medi-Cal covers. But here's a catch-22. So to qualify for Medi-Cal, we already know you've got to have a very low income, right? But let's say you have a little bit of maybe above that income. And now we have what is called the Medi-Cal property requirements, meaning like if you have, and this, trust me, I'm confused. I am not an expert on this. I don't think there is any experts. And if they say they're an expert on Medicare or Medicaid, they're lying to you, because I have read these things and I'm telling you, confusing as hell. So, you know, they have property requirements. And then if, you know, you're not eligible, just meeting that income requirement. And property is defined as, you know, buildings, homes, mobile homes, estates, mortgages. Yeah, like all of that. Why are we talking about property? You cannot have property to get insurance. Why are these two married together? This makes me very nervous. And so when I have an elderly person in a nursing home who may need to stay there long term because they just couldn't get back to that prior level of function, they're facing maybe the end of their lives, their family works because they're essential workers, they can't take care of them. And now we're at this moment where you need that long-term care, but you don't have a secondary insurance. We're trying to get you qualified for a secondary insurance, but maybe mom, you know, she might have a little bit too much money in her savings account. So to qualify, she can only have $2,000 in reserve. So let's say mom had $3,000 in her reserve, just $3,000. That's not a lot here in California. That's not a lot anywhere in this country. If she had $3,000, that could bump her off for qualifying. What sense does that make? This is means testing. This is medical apartheid. Like when I found this, I was just, I mean, it's unfathomable. Here in America, this great country, this is what we're going through. This is what this is. And this is what you don't know. And that's why I'm here to tell you. So, you know, that is what's going on. And like I said, it's really just insane. Like, I just can't, I have to go from this slide because I'm gonna take too much time just talking about it. And so then here you see the property limits, and then with the definitions of real property versus personal property, which are supposed to be exempt. But of course, there's also caveats to exemption, like the home has to be exempt if the beneficiary intends to return home someday, but if they don't return someday, then it's no longer exempt property, basically. So it's like there's a lot of issues here, but once again, my biggest question and what I want you to think about is, why am I talking to you about Medi-Cal and now I'm talking to you about people owning property? Why are these two in the same conversation? That's what I want you to think about. So what do we need? If Medicare covers most services and Medicare or Medicaid covers what it doesn't, why can't we just combine them? I mean, and that happens if you happen to be, you qualify for Medicare and you have a low income, you can get what we call Medicare, Medicaid, and you get most of your stuff covered for very little cost. And like Dr. Song said, we're already paying for this, people. So why can't we all have it? Why do I have to pay hundreds of dollars a month in medical insurance costs? And then why do you not have to get covered because you make just too much to get qualified for Medi-Cal when we could really just have it all? AB 1400. And no more means testing. The fact that Medi-Cal or Medicaid, you know, really has this written into it, the state of California, everything I've shown you in this presentation, I've pulled from, well, regarding Medi-Cal, came from the Department of Public Health Services for the state of California. I didn't make it up. it made my life really easy because I just went and snatched and grabbed it off their website. And so the same thing with Medicare. I went to Medicare.gov and just snatched and grabbed off their website. So honestly, everything I'm showing you is legit there. You know, I didn't make it up. I didn't fluff it. I didn't make it seem all bad and gnarly because I'm trying to promote people to go for a single payer healthcare system. I'm telling you exactly what I see. And then we need a better healthcare system focused on the health and well-being of the people, not profit margins. My company is telling us that we need to recoup millions of dollars because of what we lost last year. And even though they made profit, we still need to recoup it because we lost, you know, we need to get 5 million back for 2021. How the hell am I supposed to do that? And the only thing I could say is that there's about $5 million that were on that call that don't need to be there because what do we need a vice president for? I don't see one. I don't see a reason for a healthcare company. And then also just to speak corporate speak, because now I've learned it, investing in the health of the people yields greater returns on investment than any for-profit healthcare system. Meaning if we invest in you, keep you healthy, you work, you pay taxes, and the world keeps spinning. But if I let you get sick and then I prevent you from getting health care and you stay sick and you get sicker, now I'm paying you disability. What sense does that make? And that's where we are right now. So there you go, people. In a nutshell, very high level. I did not go down a lot of the rabbit holes I could have, but I only had 20 minutes, folks. So thank you.
Marvelous, Jeanna. Thank you so much for preaching the truth. We have Dr. Paul Song preaching the truth. We have Jeanna Harris preaching the truth. And now we're going to have Dr. Belk preach the truth. Betty, are you going to introduce Dr. Belk? Thank you, Jeanna. Betty, you need to unmute.
Yeah, I'm sorry. Somebody shared the screen and I was not ready for that.
Oh, sorry.
Okay, that blocked everything out, including my frame. But welcome again, everybody. I've been monitoring the chat. I will do my best to relay your questions at the end after Dr. Belk gives us all of his wonderful thrilling and disgusting information about how the insurance companies rip everybody off. So I'm going to introduce Dr. David Belk. He's a graduate of the U.S. School of Medicine, At..RN, and currently an internal medicine solo practitioner in Northern California. Years ago, David Belk really realized that neither he nor his colleagues had any idea what patients were being charged for various services outside of their offices. Dr. Belk's devotion to his patients led him to question why they were paying so much more than the actual cost of covering their healthcare needs. Dr. Belk has spent the past 10 years researching hospital billing, insurance fees, and pharmaceutical prices, sharing his research findings with the public on his website, The True Cost of Healthcare. Dr. Belk has untangled and demystified healthcare costs. The shocking truth emerged that the American public is being legally scammed. Discovering that the actual cost of our healthcare services in the U.S. are typically hidden, deceptive, grossly inflated, and the result of industry collusion led Belk to publish The Great American Healthcare Scam: How Kickbacks, Collusion, and Propaganda Have Exploded Healthcare Costs in the United States. Welcome, Dr. Belk, and to tell us all about your wonderful book and all the information you have gathered. Thank you so much.
All right, thank you. Okay, so I will start with medical bills. They aren't what you think they are. Is my sound okay? Yeah, okay.
Great.
All right, so one of the first things I like to tell people about medical billing charges in the US is that medical billing charges are by and large works of fiction. And that doesn't sit well with most people. I mean, what do you mean works of fiction? These are legal documents. How can they be works of fiction? So to show you what I mean, I'll walk you through some medical bills complete with the payments. This first one I really love. Okay, so this is for someone who got superficial sinus surgery as an outpatient at Pacific Surgical Center in December of 2015. Now, you notice the top line there. It says the amount billed, total amount billed, $97,140, which is a lot for about an hour of surgery. This patient was never admitted. They checked in the morning. They were home by noon the same day. However, don't worry, nobody paid most of this. You can see the line immediately below that is the discount on that huge billing charge of more than $92,000, or roughly 95% of the initial invoice. The total amount actually paid by anyone to anyone for this, you can see that Cigna, his insurance, paid $3,562. The patient paid an additional $890. So a total of $4,400, or roughly $4,400, was paid by anyone to anyone on this bill of more than $97,000. Now, at this point, people often ask me, yeah, but what happened to that other $92,000? Nothing. It never existed. Okay, it's like asking, what does the tooth fairy do with all the teeth she collects? The tooth fairy doesn't exist, neither do most of these billing charges. Okay, here's another bill. So this is for someone who had a 3-day hospitalization. So this time they were hospitalized for eye surgery at Altapate's Medical Center. All right, so the total billing charge is again enormous, more than $126,000. But as you can see, 2 columns over, there's patient savings. That's the discount, more than $107,000. In this case, roughly 15% of this bill was paid by anyone to anyone, a little over $19,000, $19,500, and the rest, more than 85% of this bill, simply vanishes. It never existed. It was a work of fiction. So 15% was paid on this bill. Here's another bill for someone who had a 2-day hospitalization at Sanford Medical Center for abdominal surgery. Again, not really serious. She was home in 2 days. Again, the billing charge is nearly 6 figures, more than $91,000. Inexplicably, you can see that the third line down, what the plan paid was 60% of this bill, nearly $55,000. So the discount isn't nearly so generous. Why? Who knows? It's only money. Now, if you're confused by this, well, just wait. I saved the best 2 bills for last. So this bill is for a middle-aged woman who had a hysterectomy at Altapate's Medical Center in Berkeley, California, and has United Healthcare as her insurance. This bill is for a middle-aged woman who had a hysterectomy at Altapate's Medical Center at Berkeley, California, and has United Healthcare as her insurance. Okay, what's the difference? In the case of the first bill, this was for a woman who had her surgery as day surgery, done the same day. She checked in that morning. She was home by noon the very same day. All right. This is for a more complicated procedure. The woman was hospitalized for 3 days for her hysterectomy. Now, as you might expect, Altapates billed United Healthcare a lot more for the 3-day hospitalization than they did for the day surgery. You can see towards the left there on the bottom, the amount billed, total amount billed was $86,132. That's the bottom line. Okay, whereas for the day surgery requiring no hospitalization at all, Altapates only billed a paltry $41,150. All right, so less than half was billed for the day surgery than for the 3-day hospitalization, which is what you would expect. But inexplicably, the payment, total payment for the day surgery was more than $29,000, which was 70% of that billed charge. Whereas the total payment for the 3-day hospitalization, you can see in the bottom center, the plan, United Healthcare paid $10,153, and the patient paid another $2,700, meaning the total payment for the 3-day hospitalization was less than $13,000, whereas the total payment for the day surgery was more than $29,000. Okay, what are we seeing here? Chaos. Not only are hospital billing charges basically works of fiction, the payments have very little to do with the charges, and they also have almost nothing to do with the medical services provided. And this is by design. You see, if you have no idea how much ought to be paid for a medical service based on either the billing charge or even what service you got, you have no idea when you're being overcharged. And guess what? You are being overcharged most of the time. Now, we'll get to specific examples of that in a few minutes, but first I want to show you some actual data here. So this is from CMS Medicare cost reports. This is basically billing charges, total billing charges and total payments for all hospitals in the United States between 1996 and 2015. As you can see, in 1996, total billing charges, which is the blue bar, exceeded payments by about 75%, which means hospitals in general billed a lot more, but not nearly as much as they did in 2015, when total billing charges, which exceeded $3 trillion, they exceeded the payments they collected, total payments they collected, by about 3.5 times. So billing charges have really ballooned on average in relation to payments. All right. Now you might ask, why are hospitals putting up with this? Why are they putting up with such a chaotic payment system in which they probably have no clue most of the time how much they're going to get paid for a medical service? And on average, they only collect about 28 cents for every dollar they bill. Why do hospitals put up with this? Well, it works for them. This is from the American Hospital Association. According to them, since 2012, hospitals have had an average 8% profit margin, meaning that 28% that they collect on those bills is on average 8% above all their expenses. And that's really a sweet deal for them, especially when you consider vast majority of hospitals in this country are nonprofit, meaning they don't even owe any taxes on all that profit. All right. Now, how does the system work against you? Well, let me count the ways. Actually, I'll just give you one example because this is a short presentation here. This is out of the Los Angeles Times, right? And this was a case of a patient who definitely caught them doing this. She had a CT scan at a Long Beach hospital, and the billing charge for that CT scan was over $6,700. Now, she was on a high deductible, and so she had to pay for the whole bill herself, but because she had Blue Shield insurance, they got her a 67% deduction, so she only owed $2,300, a little over $2,300. Well, she suspected something. She called up the hospital shortly after she received this bill and simply asked them, how much would I owe for this exact same CT scan if I simply paid cash and wasn't insured? And the hospital quoted her a price of $1,054, less than half the deal Blue Shield got her. Okay, now this doesn't mean that a single person picking up a phone has more negotiating power than a giant insurance company with billions of dollars in revenue and millions of insured people. No, what it means is that the insurance company deliberately inflated her bill largely because it was her money. All right. And if you're seeing this and you think, well, hey, maybe I should just go without insurance if they're cutting me such raw deals. Well, good luck with that. Okay, this is the billing charge for someone, Jeff Cortan, who in 2012 had a minor bicycling accident. He fell over on his bike, hit his head. He was taken by ambulance to Mercy San Juan Hospital. He was in the emergency room for less than an hour, received a few stitches, a CT scan, a tetanus shot, sent home, got a bill for $31,613. The Cortans had no insurance. They had to deal directly with the hospital themselves. They called them up and the hospital says, yeah, well, if you pay us now, we'll cut it down to $18,000 for less than an hour in the emergency room. Here's the thing. A hospital can cut you a deal if they want to, but they're not really obligated to. Meaning, if you need acute care, you're there for a stroke, a heart attack, a broken hip, whatever, you got to go to where they'll treat you and worry about the bills later. And it's up to the hospital how nice they want to be to you after the fact. In the case of the Cortans, the hospital wasn't nice at all. And that brings me to what's in it for the insurance company, this system. All right. Insurance companies, by and large in the United States, serve as protection rackets. They're far less about covering needed medical services than they are about protecting you from fictitious overbilling. You don't want to go through us? Good luck with that. Here's that $95,000 bill for your hour of surgery. You deal with the hospital. And since it's a relatively no-cost service for them to simply reduce these bills by gargantuan amounts, and they get so much cover because the billing charges are so many times above what a fair payment would be, it's really easy for them to manipulate these bills and make it look like they're saving you a lot of money. Yet, how much does it cost you not to have this protection versus how much it costs them to offer it? And you might be thinking, well, okay, obviously the insurance company likes to spend a lot of money when it's my money and they are offering this protection racket, but at least when it's their money, they're being stingy and they're saving overall, right? Wrong. When it's their money, you have to understand, an insurance company is simply a universal middleman. All right? Money goes through them. They keep a cut of however much money goes through them, meaning the more money goes through them, in other words, the more overall healthcare costs, the larger their cut is, even if it's a fixed percent of what everything goes. In other words, the more everything costs, the more they keep. All right? This is from the SEC filings of the largest for-profit insurance companies in the United States. All right. So the blue line is the total revenue that they took in each year from 2003 to 2017. The green line is the revenue that they collected from premiums, and the red line is how much they spent in overall healthcare costs. All right. So the red line stays pretty close to the green line. All right. They love to tell you that on average, they spend about 80 to 85% of everything they take in healthcare costs. So they have to make sure that whatever they take in premiums, they got to spend about 80 to 85% of that actually in healthcare costs. That's what's called their medical loss ratio. It makes it look like they're not wasting money. That's how it appears. But here's the problem. Even though they are obligated to spend most of what they take in on healthcare costs, they're not obligated to spend that money wisely. They can dump it. And guess what? They do, because they can spend more or less on those hospital bills depending on, depending on how much comes in at a whim. And then whatever extra they spend, they can add it to your premiums the next year, right? And they can keep raising your premiums and showing you those hospital bills and saying, this is why your premiums are going up, not telling you the fact that they could have paid a lot less on that hospital bill and the hospital probably wouldn't have even noticed. Here's another way of looking at it. Oh, excuse me. Also, since they have relatively fixed profit margins, you can see their profit margins are always, 3 to 6%. They vary somewhat, but they're in a tight band of 3 to 6%. Well, here's the thing. 3 to 6% of $500 billion is a lot more than 3 to 6% of $100 billion. As long as they keep their revenues rising, and the only way they can keep their revenues rising is to keep their costs rising, that 3 to 6% is an ever-growing pile of money. That's how math works. And here's another way of looking at it. This is from California's OSHPD, all right? So this is the total, this is the average amount spent per hospitalization for all hospitals in the state of California between 1995 and 2016, all right? Now, the yellow line is Medicare, excuse me, how much Medicare paid for each hospitalization on average. The green is how much Medi-Cal spent for each hospitalization. And the purple is how much private insurance companies spent for each hospitalization. Interestingly, back in the 90s, private insurance companies, Medicare and Medicaid, all spent about the same amount on average per hospitalization in California. And even though between 2000 and 2016, you can see what Medicare and Medi-Cal paid was about doubled, what private insurance companies spent skyrocketed to, by 2016, about twice as much on average per hospitalization as what Medicare and Medi-Cal paid, all right? And you got to figure, now, Medicare covers the elderly and the disabled. Medi-Cal covers the impoverished. Why does it cost so much more to hospitalize a privately insured patient who is typically younger and gets their insurance from their employer? Shouldn't it be the opposite? Well, the private insurance companies make more by spending more. And that's how they keep your premiums rising so quickly. So if you want a bottom line to all this, if you're talking about a free market, and for some reason people always like to talk about free markets in healthcare, even though they have nothing to do with one another. But in general, the idea of a free market is that you have buyers and you have sellers. The buyer naturally wants to get the lowest price for any good or service. The seller wants to get the highest price because it's money. All right. And supposedly they negotiate, they meet in the middle, though he who has the most negotiating power gets most of his way, right? Okay. In healthcare, the way it works now, you have providers, which are basically sellers. You have the consumer who needs the healthcare, and you have this universal negotiator whom we go through for all pricing. All right. Well, here's the problem. The provider still wants the highest price he can get because it's money, but the negotiator, your insurance company, also wants prices to be as high as possible so that more money goes through them so they can get more. How do they pull this off without the consumer figuring it all out? Simple. You create a billing and payment system that's so incredibly confusing and convoluted, no one knows how much anything ought to cost. Then you give everyone the impression that everything is so incredibly expensive, you must go through the insurance for everything. Show them those bills to prove it, right? Even though the bills are works of fiction. Then you can rob them blind by overcharging them every time they need health care, and even when they don't, because that's, why your premiums are so high. How's that for a scam? Questions?
Thank you so much, Dr. Belk. It's an incredible scam. Thank you all for demonstrating to us why partial reforms are not the solutions. Thank you, Dr. Song, for reinforcing what we know, that separate is never equal. And for Jeanna, that a tiered system treating some lives as worth more than others, as in Medicaid and Medi-Cal, versus private insurance, having some people's health needs better funded than others is apartheid. So leaving our lives in control of the business incentives strips the care out of a healthcare system. So as everyone has demonstrated, health insurance is not health care. Care requires investment of our resources in our needs. For-profit insurance, hospitals, and drug companies extract our resources away from our needs. A for-profit predatory system holds us hostage, as Dr. Belk has shown us. It's your money or your life. And that is actually extortion and a protection racket. So we see that this must be removed. The tiered care must be removed. Insurance industry, for-profit industries must be removed from the system and replaced with the publicly funded single plan for all. So equality, decency, and human dignity require that all means all. Every day is an emergency for someone. Every day is urgent. And the fierce urgency of now means now. So when the governor, the legislators, and all the residents of California receive the exact same care, three things will happen. We will have everything we need. It will be top quality, and the funding will always be there. That's why our mantra is everybody in, nobody out, equally. Single payer, universal health care for all now. So together, si se puede. So now it's your turn, attendees, for your questions of the panelists. We have about 60 people on the Zoom from Maestro, last time I looked, and we have a handful of people here on our Healthcare for All Maestro. So the questions will be read by Betty from Maestro and Erica on our Healthcare for All LA Zoom. So thank you, panelists. And here comes the tough part, the questions.
So I guess I'll take it first. A lot of outrage and also a lot of gratitude on the chat here at the CPA convention website. So your information, panelists, has really hit chords all along. There are several questions, but I'll start with one, which is related to Medicare, and there were a few of them, and this one says, I guess it was at the point, and this is from Candace, were you saying that if a person has a Part B and Part C, they have double coverage? And then she says, and I've heard Ralph Nader call it Medicare disadvantage.
Actually, no. So you can't, well, actually this week, I'm dealing with a situation where someone does have B and C, and you should not be able to have them together, as far as I know. So once again, going to what Dr. Belk said about the chaoticness of the system, but technically, no, you should not be able to enroll in Part C. It's either or. You can have A or B, A, B, D in a sense, or you can have C. C's in its own little universe over here. And then, yes, it is Medicare disadvantage. Why? Because plans do cherry pick, and they do send their recruiters to doctors' offices to pick out the patients that they want to apply. Granted, we are not allowed to discriminate. We are not allowed to say that, oh, well, you have cancer, so we can't enroll you. But trust me, they have their ways. So there's that.
Jeanna, they may have been talking about the Medi-Medi.
Oh, well, yes, you can have Medicare and Medi-Cal. So you can have both if you qualify. Very slim, narrow qualification there, but you can't have Medicare and Medicaid.
Usually when you have Medicare, Medicaid, it works the same way a supplemental plan works. Medicaid simply picks up the deductibles and co-insurance and the drug costs that Medicare doesn't pick. So
exactly.
So it's added coverage, not exactly double coverage. If somebody has double coverage, usually one or the other, or perhaps both, are going to refuse because there's usually confusion and a fight as to which exact policy they have. But if you have an Advantage plan, sometimes that does get confused, I guess you could say. But normally the Advantage plan simply takes over your Medicare completely, and then if the doctor tries to bill Medicare, they just get a denial.
A lot of that happens.
Yeah.
So another question, I believe, on the Medicare and Medi-Cal discussion. This is from Robin. She wants to know, if you earn less than $17,000 but have more than $2,000 in the bank, you do not qualify for Medi-Cal?
So, it depends. Once again, and Dr. Belk probably has seen this, if they look, if they see, okay, you meet income requirement, just hit approve, then they might not have, you might skim through. But if they look, then they may, say, but if you hit the income requirement, they should not make you then go into the that reserve, because you've already met that modified adjusted gross income. But like I said, it is confusing AF. And a lot of times when that property reserve really applies to seniors, and it's really affecting them greatly. Like, our poor seniors are falling through this gray area like nobody's business, being left without food, left without health care, because they're paying most of their income in healthcare costs and rent, and then they don't have anything for medications and anything for food. So this really greatly affects our senior population more than anybody else.
The other thing that most Medicaid programs do, and I assume Medi-Cal as well, is if you have property or money, but no income, you can qualify for Medi-Cal. However, and this doesn't affect you personally, it simply affects your heirs, when you do die, whatever estate you leave to your heirs, the Medicaid program will deduct whatever expenses they paid from that estate. So it's kind of a payment after death system. So technically, you could have a lot of money parked away, still qualify for Medi-Cal because you have absolutely no income, but then they take it from you after you die. So that's one of the ways that they recoup their expenses if you do have money but no income.
It's disgusting. That's the only word you can use. It is absolutely disgusting.
And that's where we say, you know, gains for the middle class are lost because of our healthcare system when we have our elders that we need care for, and now people are working 2, 3, 4 jobs. They need the care, they need the help, and then what happens is that any kind of that wealth that they accumulated in their home, which is a middle class dream, is then lost to their children. And this is a tragedy of our system. And yes, single payer now.
And that affects people of color. So grossly affects people of color. They want to know why there's a generational wealth gap in the Black community. Well, we just told you.
I'd like to add there's more than a generational wealth gap. In 66 other countries, Black residents and white residents have really the same health outcomes. It is only in the United States, which is also the outlier for having an for-profit insurance system run the show. It is only in the United States that we have horrible gaps in health outcomes and in longevity. That does not exist in 66 other countries that have some kind of single payer system.
Okay.
Erica, do you have any questions right now? No.
No,
Okay.
I don't.
Okay, where are we on time, just to ask?
8 minutes.
Yeah.
8 minutes. Okay. So, okay, well, let's just take this question, which has, it's regarding, this is from Isaac, excuse me, I should probably have my glasses on. This is from, okay, Isaac. He says, in general, I believe this is a question, without accountability, how can we pass single payer now? How can we hold our electeds accountable in a way that increases our chances of passing single payer AB 1400 this time around? I mean, I think this question can go to Maureen, or it could go to any of the panelists, Jeanna, Dr. Song.
Yeah. The only thing I will say is first of all, thank you for the great work that you all are doing on this. But ultimately, we have to get the governor to buy in as soon as possible, right? And lead the efforts, because that was what was lacking with 562. Governor Brown ran away from it, privately pushed some of the people in the assembly to do everything to block it. You have a governor that supposedly ran on being a single payer candidate, who signed a waiver when we had a Republican president on the very first day of his term, but now we have a Democratic president and has not signed a waiver since then. But ultimately, if he stood up and said, okay, I want to lead on this, I want to really work with our assembly to do it, I would suspect it would be a much different climate than where we are right now. So, I think the work that you all are doing to try to get a petition, trying to get enough people to sign to really pressure the governor, particularly in lieu of a pending recall, it would be really important for his leadership on that. So I everything aside, with the coalitions and everything are great and much needed, but unless we have the governor really step forward and say, I'm going to do this, I think we're going to run into a lot of the problems we ran into before with 562.
I just wanted to add, so, like I said, I've learned to speak corporate speak. And that really is something I'm going to take with me to legislative visits. So the thing is pointing out, like, I know what the lobbyists are going to come and say, and actually having the talking points to talk against that, talking about why this quote unquote, value-based healthcare system that they think works doesn't work, because that's what they're going to go to them. And if you were on Healthy California Commission hearings over this past year, which were complete waste of time and money, then you heard them talk about value-based care, value-based system. And that's what they're going to continue to talk. And we know that they have the ear closer to, Gavin Newsom and a lot of the high level elected officials. And so really, I think being able to oppose those talking points with just as valid, and then having the numbers, like I harassed the hell out of Miguel Santiago and kept asking, what does Gavin want for single payer? What does he want? And he said, how are we going to pay for it? And my response was, what's his Venmo? I'll send you the money because it's there already. I've got the money. It's just that you don't want to know, you don't want to see that we have the money. And I said, those are the talking points we have to go out, because if we talk compassion, which you would think would work for any other human being, it doesn't quite work for them.
Thank you. I have a question from our Zoom operator, Paul Newman. The question is for Dr. Belk. He asked, so basically the super high bills cause the final net bill to be higher than it should be, correct?
Yep. Simple as that.
That was a very straightforward answer. Thank you. We still have time for more questions. Do you have any more questions, Betty?
Well, the couple of questions I have is about what can we do? Just like that question, what can we do to support the single payer efforts here in California, support AB 1400. So they all seem to be going that way, except for one, which was from Christina Montalvo, who has a question about the workers' comp medical system. And I believe she says, and how do the people who run the single payer campaign feel about workmen's comp medical system? So, possibly me misinterpreting what she said, but maybe she wants to know, how is that all going to be handled? Where is that going to go in a single payer system?
That is a good question. And actually that was posed to me before, and I did not have the answer. And unfortunately, I still don't have an answer. I think that is one thing that we are going to have to talk about, and maybe ask Assembly Member Kalra or one of the co-authors of the bill on how, if they've thought about it. They may not have thought about this. I mean, I'm sure they have, but let me tell you, the workers' comp system, coming from someone who dealt with workers' comp for 2 years, is absolutely horrendous as well. And so, I mean, honestly, if you're covered under AB 1400, everybody has care covered. You should honestly, workers' comp should just be compensation now for you to be paid from your worker for your injury, and should not have anything to do with your health care. Because my back injury that I could have recovered from probably fairly quickly, because I was only in my 20s, took 24 months, 3 procedures, and I had to fight for every therapy session. But if I had AB 1400, that would have been separate, and I just needed my job to run me my money for injuring me. So that's how I see it anyway.
One thing I will say for businesses, though, also, if you don't have to worry about covering that person's healthcare costs in perpetuity because of an injury sustained at work, which would happen under AB 1400 or any single payer bill, it ultimately will reduce your costs as well.
So if there are no other questions, I will launch into what Healthcare for All Los Angeles is doing to support AB 1400. But I just want to check with you, Betty. Are there any other questions?
Well, most of the questions have to do, and I'll say one from Justin Sampson, and he's a congressional candidate in Orange County. And he says, what do you see is the best way to educate voters in the district and county about the need and urgency to pass Medicare for all the state and national levels? So this is going to be a great segue. Also, what do you think? What are the new strategies for passing single payer? So there are a lot of questions about what people can do, get active and activated and educated, which are, I think, our campaign, which is very complementary to AB 1400, can help people get involved. Also, the other thing is people are asking about the slides, and if they could possibly get those slides so that they can educate their, whoever their groups and people they reach out to. And I see Paul nodding his head, which says he will be sharing them. I'm not sure if, and I guess you can also reach out to us at info@hca.la, and we can also and ask for those slides, and we'll try to get you as many those slides that we
I have a YouTube channel with a number of YouTube videos, including a fuller presentation of this entire thing on my YouTube channel that anyone can watch. It has all the slides and everything else, including even more information. In fact, there's a large number of videos, and of course you can go to my website at any time. So all the information that I have is on my website, and much, 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 much more. If you just go to truecostofhealthcare.org or just type my name into YouTube, and you can have fun reading all the nasty comments on my videos as well. I mean, that's entertainment in and of itself.
You must be effective.
Yes, it must be really effective.
Or if you're ignored, you're also effective. Okay.
And
Well,
just to let anybody else know that they're asking about recordings and this kind of thing also, we at Healthcare for All will probably have it on our YouTube, Healthcare for All Los Angeles. You can find us on Facebook at Healthcare for All Los Angeles. You can find us on Twitter and Instagram at HCA, I think it's underscore Los Angeles. And we'll have all those recordings for you too. But I'm going to hand it over to Erica to tell us a little bit more about the campaign and how to get active for AB 1400.
yes. So there was a long time between SB 562 and AB 1400. And on New Year's Day, we at Healthcare for All Los Angeles kicked off a campaign called the First 100 Days campaign. Dr. Song was with us on that kickoff. And it was really to urge Governor Newsom to live up to his campaign promise to give California single payer now. So we started this campaign, and then lo and behold, into our campaign, the nurses came riding up on their horses and delivered CalCare. That's AB 1400. That is our California single payer bill. CalCare would guarantee comprehensive, high quality healthcare for all Californians as a human right, leading the nation in the larger fight for healthcare justice. So we adjusted our First 100 Days campaign to support the passing of CalCare. So we still, we have 3 asks of the governor, which are pretty much the same, but those 3 asks are that Governor Newsom lobby California state legislators to pass the CalCare bill, AB 1400, in the Assembly by June 4th, and for the state Senate to pass it by September 10th. Our second demand is that he begin the application process. You heard Dr. Song mention this, for the necessary state innovation waivers from Health and Human Services. And then our third ask is that he publicly pledge to the people of California that he will sign this legislation, this single payer legislation. For our California legislators who are largely Democrats, we have a super majority of Democrats. We have 3 asks of them. Number 1, that they sign a pledge that we have about not taking money from the medical industrial complex, which is not only health insurance companies, pharmaceutical companies, but also medical device companies, hospital, clinic associations, their foundations, their PACs, et cetera. That our legislators hold constituent town halls on AB 1400, on the CalCare bill, and that they prioritize CalCare, that they prioritize it with everything they do, putting it on their website, in their social media, press releases, the whole thing. So that is some of the things that asks that we have, but how you guys can get involved with us, how you can join us on this, is we're asking you to call Governor Newsom and asking you to tell him support CalCare, past CalCare, signed CalCare, for you to call your assembly members. If they've signed on, ask them to champion it. Get out there publicly. If they haven't signed on, get them to sign on. The nurses are organizing legislative visits. We're supporting that. We're working with the nurses on that. We have a social media storm every day. So every day at, I would say by 12 o'clock, go to Healthcare for All Los Angeles, our Facebook page, our Twitter page, our Instagram page, and just like our post, comment on our post, share our post. You can go, Betty just pulled it up, you can go to our website, healthcareforalllosangeles.org, and you can join the campaign right there at the top. You can read all about the campaign. We also have actions that we do. We're joined with other organizations such as PANA, fighting to save a nursing home that they were about to close, fighting to save smaller clinics that they were about to close and merge for corporate profit. So we have our social media you can do every day. We're asking you to call the governor, call your legislator, call your assembly member, asking them to sign on, support, and pass the CalCare bill, and then come and check out our website and join the campaign. That's my 5 minutes.
Thank you so much, Erica. 1.2, we can each contact our legislators and tell them that we would like a town hall for constituents to discuss AB 1400. If we each ask your legislators to hold a town hall, ask them to put on their website that they support it, ask for press releases, ask for social media statements that they support 1400. Somebody asked, well, we've asked our legislator, they won't show up. You have an empty chair and you put the big name on the empty chair of who that's supposed to be, because your legislator is actually supposed to be asking us what we want and what we need. That's part of the job, right? They are our employees. We do elect them as our employees. So anyway, thank you so much. We really appreciate the wonderful information presented by Dr. Song, Dr. Belk, Nurse Jeanna. Really thanks to all of you. You're all amazing champions in this quest to finally get a decent healthcare as a human right for each and every one of us equally. Do you have any last things to say? No? Okay, then just say we love you all. Thank you.
Love you
Anything
all.
else?
You all.
Love
I
you
love
all.
you all. Thank you. And check out the chat. There's all kinds of links in the chat to resources. Thank you so much. Take care, everyone. Onward.
Thank you.
Everybody in, nobody out.
All right.